Good evening. I am Dr. Max Gomez. I'm the senior medical correspondent for CBS here in New York, and welcome to our next installment of the ongoing Columbia Children's Health webinar series. And tonight we're going to talk about something that I think is really very important. It's mental health in uncertain times, fostering resilience in children and adolescents. And I think it's something that, as we'll get into a little bit later, we sort of assume that people are either resilient or they're not, but it turns out that we can actually, I think, do something about it and foster this in children. As many of you know, our previous webinars have covered such disparate topics as preparing children for surgery, COVID vaccine safety, heart and immunological issues in kids, and the somewhat poorly understood MIS-C syndrome in children. But tonight we'll tackle what I think has been a bit of a lost issue during COVID-19, certainly one that many of us have been hesitant to discuss, especially when it comes to children. And that's the impact that this pandemic has had on our children's mental health. But no longer, because if we can't talk about it, we can't do anything about it. So we're going to talk about it tonight. And here to introduce our distinguished panel is Dr. Warren Ng, Director of Clinical Services, Child and Adolescent Psychiatry, and a Professor of Psychiatry at the Columbia University Medical Center. Dr. Ng.
Thank you so much, Max, and good evening, everyone. It's such a privilege and pleasure to be here with you all. So I have the honor of presenting our wonderful panelists, our esteemed panelists of pediatricians, child psychiatrists, and child psychologists. So first, we're going to have Dr. Sarah Ann Anderson-Burnett. She's an assistant professor of pediatrics, associate program director for the Adolescent Medicine Fellowship, and inaugural diversity, health equity, inclusion, and justice quality lead for the Department of Pediatrics at Columbia University Irving Medical Center. She's a graduate of Xavier University of Louisiana and the Icahn School of Medicine at Mount Sinai. Dr. Anderson-Burnett completed her pediatric residency and chief residency at NYP, Morgan Stanley Children's Hospital. Her area of interest and expertise is substance use disorders and adolescent mental health. Currently, she's leading the development of an equity-driven clinical practice pathway for the management of cannabinoid hyperemesis syndrome in adolescents. In sum, Dr. Anderson-Burnett's academic career demonstrates a longstanding commitment to health equity by incorporating this principle into clinical and scholastic frameworks that serve to advance health justice in pediatrics and beyond. And next, we have Dr. Evelyn Berger-Jenkins, is a general pediatrician at the Charles Rangel Community Health Center in Harlem and a pediatrics faculty in the Division of Child and Adolescent Health. She's devoted her career to clinical work and public health research and improving the identification of mental health concerns in primary care, as well as addressing disparities in mental health diagnoses across the services. She's the NYP Presbyterian Hospital physician lead for the Mother and Child Integrated Mental Health Program, Turn to Us school-based mental health program prevention, as well as the Family Peace Trauma Treatment Program. Next, we have Dr. Laura Mufson. She's a Viola Bernard Professor of Medical Psychology and Psychiatry at Columbia University Irving Medical Center and Associate Director of the Division of Child and Adolescent Psychiatry in the Department of Psychiatry at Columbia University, as well as the Director of Clinical Psychology at New York State Psychiatric Institute. She's a developer of the adaptation of interpersonal psychotherapy for adolescent depression, IPTA, and emotion-focused psychotherapy. Dr. Mufson has an active research career studying the efficacy and effectiveness of evidence-based psychotherapies for children and adolescents with depression and anxiety. She's an author of 9 books, as well as interpersonal psychotherapy, including The Adaptation for Depressed Adolescents, The Adaptation for Prevention of Depression in Adolescents, and Family-Based Model for Pre-Adolescents. Dr. Mufson is a fellow of the American Psychological Association Division 53, Society for Clinical Child and Adolescent Psychology. Last but not least, We have Dr. Jonathan Slater, received his BA from Harvard University, MD from Columbia University, College of Physician and Surgeons, and completed his postdoctoral research fellowship, adult psychiatry residency, and child fellowship at New York State Psychiatric Institute, New York Presbyterian Hospital. Dr. Slater was certified in psychoanalysis by the Columbia University Center for Psychoanalytic Training and Research, and is a member of the American Psychiatric Association and the American Academy of Child and Adolescent Psychiatry, as well as being the clinical professor of psychiatry and pediatrics at Columbia University Bachelor's College of Physicians and Surgeons. So as you can see, you have an incredible panel of experts and esteemed colleagues who will share wisdom and insights tonight. Thank you.
Good deal. Thank you, Warren. A couple of quick housekeeping items. I have asked for and gotten permission from our panelists to address them by their first name. So no disrespect meant. It is so we can have this as I think, a less formal discussion this evening. And also, if you have any questions, you can put them into the little Q&A box at the bottom of your Zoom screen there, and we will try to get to that as we weave it into our discussion as we move along this evening. And finally, we are in fact recording all of this, and it will be up tomorrow on the Columbia Children's Health YouTube channel. So it's a channel on YouTube, Columbia Children's Health, and you can go back and refer to all of this. So let's get started with, well, maybe we should get started here, Warren, with talking about the national state of the mental health emergency. Are we in an emergency here? And where did that come from, and how do we get out of it?
Thanks, Max. I think that we've been in an emergency status, and I think that it has only risen to crisis proportions. So it's really an acute on chronic situation, and I think that you are all experiencing that within your practices. But on October the 19th, the American Academy of Pediatrics, as well as the American Academy of Child and Adolescent Psychiatry and the Children's Hospital Association came together to declare a national state of emergency for children's mental health. What we're seeing across the country is alarming, because I think one of the things that we've seen is also the increase in our emergency department visits with children presenting with mental health conditions, 24% increase from the year before the pandemic for 5 to 11-year-olds, but 31% increase for those 12 to 17. I think what's really alarming is really the fact that there's also limited amount of services for many of these kids within the communities, and it's very hard to access the necessary mental health services, because we were already in a crisis before the pandemic, and the pandemic has made everything worse. And we appreciate the pandemic has been really a silent epidemic of mental health conditions, and it's really stressed a lot of the systems that had been not really adequately serving our mental health needs before, but have really collapsed under the weight of the pandemic. The other thing that's really important is really the disproportionate impact on our communities of color. Similar to COVID-19 and the disproportionate impact on Latinx as well as African American communities, with twice the death rate of white or Asian communities. One of the things that we've also seen is really the orphanhood. So 140,000 children in the United States lost a parent or caregiver during the 15 months of the pandemic. The important thing here is also the fact that 91,000 of those were minoritized children, so heavily affecting children who are African American as well as Latinx, as well as Indigenous. So I think really appreciating the fact that those are some just numbers, but I think on top of a particularly challenging position. Before the pandemic, 1 in 5 children had a mental health condition or a behavioral health disorder. The majority of those kids, 50% of all kids arriving to see their adolescent provider may have a behavioral health or emotional disorder. Can you imagine what it looks like now? So I think that it's definitely been sort of a wake-up call, but there had already been a crisis before, particularly of communities of color. And how do we address that? By making sure that policymakers, legislators, as well as partnering with communities, families, as well as all of the healthcare providers to really come together for solutions for children.
Thanks, Warren. So it sounds like, not unlike the issue is for adults, that it's going to be, or has been, and will continue to be very difficult for children with any sort of mental health issue to access professionals in the field, if you will. And so much of this then, I presume, will fall upon the community pediatrician, the sort of local provider, right? So how does the community pediatrician, let me ask our panelists, all of our panelists, is how does that individual in a private practice in the community, first of all, how do you go about identifying a child who may have some issues, and such as anxiety? I mean, I presume that that's kind of the beginning of the scale that we're going to go through. How do you identify a child who may need help? Jump in, please.
Thanks, Max, for asking that important question. I think what not to do is to not avoid the conversations. And as hard as it is, we on the front lines as pediatricians need to ask these questions every single time. I'm sorry for the background noise. Every single time we see our patients. And so we see them frequently, and we do a really good job in medicine in general of asking families how they're feeling physically. We've learned how to do very comprehensive review of systems, and we ask about physical conditions and complaints ad nauseum, and we ask about problems, but we don't do as good a job asking about emotional health and emotional symptoms. And we also don't do as good a job asking about wellness. So we're always looking for problems, but I think we need to ask families how they're doing both physically and emotionally, and we need to be explicit about that. And then, you know, if they're doing well, we need to explain that, experience it with them so that they can gain some of the strengths that are needed to support their children. We can talk about how to more specifically do that with surveillance and screening. Those are the basic two ways of asking these questions. Screening is a challenge. There's not a lot of time in the pediatric visit, so we have lots of questions to ask, and screening tools are sometimes long. They take, you know, upwards of 15, 20 minutes to conduct. And so surveillance is the first step, just asking the question, those sort of one or two questions. How are you feeling emotionally, physically? And two, how are you handling the stress? If that is indeed what you're feeling, is it really affecting your function, your daily life? And that helps us as pediatricians, we're like the ultimate triagers. So that helps us to know whether we need to do some more investigation and spend some more time exploring these concerns, or if they're functioning fine, then perhaps we can provide some guidance and move on.
Well, Jonathan, let me ask you, because I think the situation is when you ask certain questions, even just plain old medical questions, if you will, there may be a hesitancy to actually be candid about it, to really be honest about what you're experiencing. I presume it's probably even more so for anxiety or mental health issues. How do you kind of bridge or break through to try to get a real honest evaluation of how a child and the family is doing?
Yeah, thanks. And I just want to thank everyone for inviting me to be here tonight, Max. You know, I think you raise a very good point in children and adolescents, which is that anxiety, for example, is what we refer to as more of an internalizing disorder, meaning that there's a lot of children who are experiencing anxiety and stress and not really talking about it. And it's kind of easy to pick up on a child or adolescent who's acting out behaviorally. And while some children, adolescents who are anxious or depressed do act out behaviorally, a lot of them aren't really talking about what they're experiencing internally. So you really rely on, first of all, their parents in terms of providing that kind of history. Sometimes you have to get corroborating information from other family members or teachers, for example, if it's possible. And then, of course, the main person to speak to is the child or adolescent. And it's extremely important in, even a time-pressured visit to try to spend a few minutes, particularly with an adolescent, and even if you can with a child alone, just to ask them in privacy how they're doing, because they may not disclose that necessarily in front of a parent, because either they're embarrassed, ashamed, right. They don't want to worry the parent, etc.
Sarah or Evelyn, I'm sorry, or Laura, let me bring you guys in because, we often hear that particularly adolescence is a time where anxiety is probably the normal state, right? How do you distinguish between the kind of anxiety that we always hear people kids going through, and particularly in high school and so forth, that kind of anxiety, and one that really sort of elevates to the level of we need an intervention or we need to talk about it?
I think that's a great question. I think most of us during COVID have gone through periods where we felt anxious or down. And I think the key thing to look at is how persistent are the symptoms? How is this kid feeling sad or down or irritable every day? If you're looking at depression, for anxious kids, I think anxiety starts young in kids, and so they can present with somatic symptoms, stomach aches, headaches, not wanting to go to school. And I think once you start to see those kinds of symptoms, and even with adolescents, we see that they start to not be doing their homework, avoiding going to school, even in COVID, not going on the Zoom school for many kids. And so I think once you start to see those behavior changes and what we refer to as impairment in their functioning, that it begins to get in the way of them doing the things that they're supposed to be doing as normal childhood activities or normal teen activities, that's when we start to think about, is this risen to a level where we need to think about them having enough of a problem that they should be referred for mental health services, or we should at least follow up and ask about how are they feeling? Are they worrying about things a lot? Are they upset about something? Has something happened in school or at home that's making them unhappy or fearful about something going on? So those are the important questions to start to ask when we see that these symptoms are persisting over a period of time.
And I think to complement what has already been said, I think it's important, like, what are some of the actual practical surveillance tools or screening tools that pediatricians can use at their disposal? Because I think, we're giving you ideas of the questions you can ask and really how you want to start to dig deep, but actually operationalizing things so that you can actually survey that before the patient even gets into the room. So I think, coming from an adolescent doc perspective, I think it's important to make your practice complementary to adolescents and understanding that they have confidentiality when it comes to their mental health care. And so, for example, what we do in our clinic is we provide every patient with a screener, the Patient Health Questionnaire 9A, which is PHQ 9A, so that we're able to at least get an assessment of that. Now, is it always going to be accurate if they're sitting next to the parent? Perhaps not, but it does give you a really great foundation to start a conversation and to make sure that, as Dr. Slater mentioned, that you have that time where you're able to have the parent step out the room and really allow that patient the privacy so that they can feel confident that they can trust you and disclose to you about what they're experiencing. In addition, we also use a questionnaire called the SCARED questionnaire to assess for anxiety as well. And it actually breaks down the types of anxiety. And I have found that to be actually very instrumental in how I'm able to navigate these patients that are presenting like this. So thinking of tools that you can actually use and then operationalize within your own system or even integrate in your own medical record systems can be really critical in starting to address that gap and actually increasing your comfort as a provider.
And if I could also add, thank you, Dr. Anderson, because I think when you standardize something, you're also hopefully not stigmatizing it so that it's universal, so everyone gets it. And these are questions that affect everyone, because I think we also have to acknowledge that stigma continues to be a barrier, not only for young people seeking the help, but also for the parents to advocate on their behalf. And so what you don't see, you might not appreciate is affecting your kids. So being able to have those standardized tools, like Dr. Anderson mentioned, really helps to sort of destigmatize and hopefully, normalize some of these behaviors so that kids know that really it's something that can affect all the children.
Well,
if I could just
please, yes, go ahead.
No, if I could just add something too, I think that the rule in children and adolescents is comorbidity too. So in addition to what Dr. Anderson was mentioning about anxiety disorders. Children usually have more than one anxiety disorder if they have an anxiety disorder. So you have to really go through a menu of things that might be worrying them or stressing them, whether it's worry about illness, worry about friends, worry about school, separation anxiety from a parent, anxiety attacks, et cetera. And very, very commonly, anxiety is comorbid with depression in children. And so often a chronically anxious child becomes a depressed teenager. So it's important just to make sure you segue from asking about anxiety once you screen into talking about, depression as well, and other types of symptoms a child adolescent may be having.
And before we move on to some of the referral questions here, let me take a kind of a half step back. The sense that I get that is so key here is developing that level of trust so that the child does feel that they can confide in you and really let that really be able to discuss what's really troubling them. Because if they're not trusting you, it's not gonna go anywhere, right? How do you, building that trust is something, it's going to be a little bit different for each one of us, but then how do we then get the child, maybe let me ask that. Do you find any particular way that you can get the child that helps to get the child trust you? And is this discussion different now in the pandemic than it had been before? What do you find is the difference now? Because we've been a year and a half or more now in this. What's changed during the pandemic?
I'm going to jump in then. Oh, go ahead, Evelyn.
I was just going to say one thing for developing trust and comfort is to acknowledge when the screens are done. Just wanted to say, sometimes we're really pressed in primary care. And so the screens provide us a score and we're glad to have some objective information and we might move on without, talking about the screen. But as Sarah mentioned, it's really important to acknowledge and thank, families for disclosing and for filling out screens. And there's a lot of false positives and false negatives with the screens, as Sarah mentioned. So just kind of going over and just saying, I see you, mentioned this, let's talk about that, I think helps families and children feel heard. And destigmatization is super important for trust. And then just normalizing. So we're all stressed. This is a stressful time. Anxiety is normal, especially at certain times of the day and certain times of our lives. And so helping them to understand that this is something we see all the time and something we can do something about helps them feel more comfortable.
Mm-hmm. Have the numbers gone up now during these last 18 months? Are you seeing it manifests itself as increased anxiety or depression or whatever in this last year and a half or more?
They're both about double, right? I think we all have seen where baseline rates are around 7 to 10% across the country for both, I think, anxiety and depression. They're now about 20%. Wow. Different in different settings, but doubled.
Yeah, and I think sort of echoing what Dr. Berger-Jenkins is saying is that there are communities that are more impacted than others. So similar to talking specifically about minoritized children, communities of color. So not only in terms of the COVID-19 pandemic losses and deaths and the bereavements that have occurred, but also in terms of the fabric of their family as well as the community, whether or not it's financial stressor, housing stressors, food insecurity, et cetera, or immigration that have heavily impacted how that child lives. Because remember, children live within their worlds and that's whoever's taking care of them. And we know that adults within our communities of color have also been disproportionately impacted. So if you're a caregiver and you've suffered a loss and that you've suffering from depression and anxiety, and we know that anxiety rates have tripled and depression rates have quadrupled for adults within this period of time, you can imagine that the caregiver is already stressed during this time. But I think that going back to your first question about the trust, I think that that's the beauty of working with Dr. Berger-Jenkins and Dr. Anderson. People trust their primary care, their pediatric providers. They have a relationship. And that's why they're less likely to see myself, Laura, and John, but they're going to see Dr. Berger-Jenkins and Dr. Anderson. So being able to you really have that relationship, allows you to have that conversation. And I think COVID-19, because it's affected everyone, is a normalizing impact. So you can say, hey, everyone's had this stress of the pandemic, like everyone is affected. So that gives you permission to talk about anxiety and depression in a way that wasn't really quite as easy before. But also in appreciating Dr. Berger-Jenkins and Dr. Anderson being a pediatric as well as the adolescent provider, there's also a developmental perspective. How you approach trust for an adolescent. I'm sure Dr. Anderson, you've got some good keys on that, and confidentiality is one of them, but that's important.
I never thought we'd find a silver lining to COVID, but I guess you identified that, Warren. Go ahead, Laura, I'm sorry.
I just wanted to add that we also know that in communities of color, our families trust their pediatricians much more. And so if the pediatrician is going to inquire and also recommend mental health services, these families are much more likely to follow through and take those recommendations because it's coming from somebody with whom they have a long-standing relationship. They see them for other issues. Oftentimes the pediatricians know these families fairly well. They see the kids on a regular basis. And so inquiring, they are the more trustworthy providers. Their recommendations are more likely to be followed than if somebody else is going to refer and evaluate for mental health issues initially.
Great, good point, good point. So I think you teed up a little bit there. The next question is, even though the pediatrician that the family and the child sees on a regular basis has developed this level of trust, that doctor may not be, that physician may not be particularly, may not have the expertise in mental health. So when or how do you then refer out when you realize that, oh, you know, I really can't handle this. I need somebody else to help me out with that. Is that an issue? And how do you then refer to some, you know, refer out from the practice, as it were? I need to start calling on people.
I can take that one. Okay. You know, I think it's a question of, you know, the level of distress and impairment and, you know, change in function that the child's had or adolescents had in terms of, you know, are they attending school? Are they eating? Are they sleeping? Are they socializing with peers? To what degree has there been real change of function and significant impairment in the child's day-to-day living and interaction with the world? I mean, obviously things like high-risk behaviors, substance abuse, suicidality, you know, agitation, aggression, you know, severe panic attacks, things like that are things that would make a pediatrician, you know, think that a child or adolescent needs more acute evaluation. So, and I think the other thing to keep in mind as a pediatrician is that a lot of issues with teens and children involve events. You know, and not a day goes by where I don't send a letter, it seems like, to a teacher. I treat a lot of college kids. You know, a kid has overslept and missed an exam, can't sleep at night. There's a problem with a teacher at school. There's a problem with another child. And sometimes someone can intervene by trying to address what that specific issue is. And they might not necessarily need a psychiatrist, psychologist, and there's a lot that one might be able to do kind of on the ground to help a child that's struggling with a specific issue and trigger that's affecting the child.
Mm-hmm. Is there a role for medication here? It just dawned on me because that's obviously very common for anxiety and depression in adults. What about in children? Sarah, you're up.
Yeah.
How's that?
I knew it was coming. So there's definitely a role for medication. And I think it definitely it comes down to the pediatric providers can do that. And in our clinics, we do that as well. And we're grateful to have great collaborators within the Department of Child and Adolescent Psychiatry. And there's also different programming that can help empower pediatricians to actually play that central role. Because as we know, although we are getting patients and we're engaging with patients in our pediatrics office, the access to mental health care providers is limited. And New York happens to be special because it has a higher rate of child and adolescent psychiatrists and psychologists per capita than most places, and we still have limitations in getting our patients there. So really, that pediatrician, that adolescent medicine provider plays such a critical role, and they play a role in actually addressing some of the structural inequities that we see that are results of institutional racism, of the syndemic that we're seeing between COVID pandemic, as well as pre-existing conditions and structural inequities that we've experienced and seen it within our populations. And so definitely medication plays a role. Each provider feels differently, but there are tools in order to help empower you, such as Project Teach, which is also a collaboration that we have many of our child and adolescent psychiatrists who contribute to. So I think just thinking about the role that each pediatrician can play, but also we love the expertise of our collaborators, and I'd love for them to jump in on that too.
There is help out there. You've got to reach out for it, though, right? I'm talking about at the professional level. Let's move up what I perceive as sort of up the scale here in terms of mental health issues, from anxiety to out and out depression. Talk to me about that, Evelyn. Tell me how do you then make that distinction that we've moved up to depression? And is that really a different, I don't want to call it a disease, but is that a different condition than anxiety? Are they really two different things? And how do you identify that? And what's the difference then in terms of what you need to do?
Right. I think, like Jonathan mentioned, they're both internalizing conditions, so sometimes hard to see on the face. And so it's important to be asking patients how they're feeling, and they often co-occur. So children who are anxious are often depressed for biologic and other environmental and contextual reasons. So just asking both of those questions, screening for both of those conditions, and realizing that they often overlap and co-occur. And then just putting it into the context of, is it, again, depression that is sort of expected and normative to an extent based on what's going on in the child's and the family's life, or is it raising to the level of symptoms that require a referral? And I think just wanted to mention on the prior conversation about referrals, I think we are fortunate in New York, and I definitely would encourage folks to call the CAT-PC phone line and things like that to get help initiating medications and making diagnoses, and then co-manage with specialists while patients are waiting to see a specialist. For depression and anxiety, there are things that we can do in the office. We just, again, try to reassure families that, these things are sort of normal, and they are, there's some things that we can do, and we focus on the positive. We try, while we're waiting for the referral, while we're waiting for medication to be initiated, we focus on the strengths, the factors, the protective factors, we call them, right, that allow the child and the family to hold on while they're waiting for further care. And that includes things like, we talk about self-care a lot, but it's really important, exercising, doing things so that your body can really have, I talk to younger kids, the positive hormones that can counter the negative hormones, and you'll feel better. There are endorphins. There are things that you can do, that will help you hold on to this until it's either over or you get further care.
Interesting. Jonathan, I saw you sort of nodding your head there. Do you want to add something to that?
Yeah, I mean, I think a lot, children and adolescents live in a bubbles, and they don't have the perspective of time. And I think listening and validating a child or adolescent's feelings and being able to listen and contextualize what they're feeling in terms of what's going on around them is important. And also stressing, number one, you're going to get help. But number two is, as much as it seems like this is not changing, it will change. And, part of it is developmental, part of it is contextual, part of it is maybe historical in terms of course, the pandemic, which is dragging on and on and on and on and on. But even now you see glimmers of hope and change in terms of adolescents being able to socialize more and get out of the house, and people are vaccinated and such. So I think trying to emphasize that depression is a condition or an illness, however you want to think about it, that is something that has a beginning and a middle and an end to it, and that when you get proper help, that situation will likely be resolved. And the same thing with anxiety, in terms of treating either with medicine or changing the way a situation is triggering anxiety. or reassuring a child. So I think that those are important things to emphasize as well.
So you bring up an interesting point there. Is it fair or accurate to tell a child in the family that there's a cure, or that there will be an end to this, because they don't have that contextual perspective, obviously? But is it fair and accurate to tell them this too shall pass?
Can I jump in? I think that depression is an episodic illness for most kids, and we find that obviously treatment helps kids get better faster, but most teens will recover from depression over a matter of time. Even without treatment, it's better to get treatment because they suffer a lot during the time that they're going through the depression. I also want to highlight, when you mentioned the link between anxiety and depression, and what we find is that kids whose anxiety was untreated or not successfully treated during childhood are more likely to go on and develop depression as a teen. So it's really important to do that recognition and pick up those anxious kids and get them effective treatment, because that makes them more vulnerable to developing depression as an adolescent, as that anxiety persists and the developmental tasks get more complex and the social life gets more complex. Then they tend to add on the depression to the unresolved anxiety. And there are things that I think pediatricians can do as they're trying to get their patients into treatment. There's for depression, there's behavioral activation, encouraging kids not to sit on the sofa and watch TV and play video games all day, but to get out, especially as they're vaccinated, to be able to engage in their social activities, encourage them to be more socially active, and to identify some pleasurable activities that they can engage in as rewards for doing the things that they're less excited about doing. They get a pleasurable activity to engage in. And so those are some things, and even journaling and identifying things that you're grateful for have been shown to be helpful for depressed teens as they're waiting for getting more intensive treatment if that proves to be necessary.
Interesting. We have what I think is also an interesting question that came in here is, what role do you see telehealth playing in treating, or perhaps in helping children and families where there are no local mental health providers, for example? This has become big during COVID. Is this something that you think is valuable, and is this something you think is going to continue, or what do you think?
I definitely do. And if there is anything that the pandemic has taught us, is what are some of the creative possibilities of delivering care where kids are at. Now, I think one of the things with all these wonderful tools is that they don't serve all kids equally. So some kids may benefit more than others. There's issues related to digital equity. So with regards to kids who live in shelters, who are lower SES, may not have the same access to the equipment as well as the broadband to really have a meaningful connection to be therapeutic. The other kids, like kids who are on the autism spectrum or other developmental delays, may not necessarily benefit, or younger children. However, there are certain interventions that are very effective. And I think I want to go back to one of your comments before in terms of, hey, does treatment work? There are evidence-based treatments for mental health conditions for children. So it's important to know that when we're not doing something, then we're not providing the standard of care that is available. So I think it's really important to know that there are treatments, and I think as Laura shared, it's reducing suffering. And every child is suffering, they're not learning, they're not thriving, and that's going to have a long-term impact on them anyways. But telehealth is huge. And I think as we're thinking about where can we be creative, how can we best provide the care to service where kids are at, we definitely see that as being a plus, and we're developing our services so that it becomes a hybrid service. So there will always be a tele component. And I think that issues related to parent work, because I think parent work is so key. And a lot of times parents don't always make it to the appointments when they're partnering with improving the lives in the world of children. So telehealth can also be a really wonderful way of doing collateral work, working with the parents, as well as other providers within that child's life, the grandparents or other caregivers, et cetera, and coordinating care with their schools. That's really important.
Have the rest of you found telehealth to be useful in your practice here?
Telehealth was transformative for our practice, definitely. It just gave us a lot of opportunity to see our patients, even see them more frequently, because it takes out that actual timing of getting to the clinic and actually going through the process of going through the clinic. So if I have a dedicated time, I'm actually able to allocate this very focused, dedicated time to my patient in a way and meet them where they're at, as Warren said. I think that's such a critical component. I've had patients sign in from school, from work, in transit, and it's that, you know, it seems, I guess some people have these older thoughts of, you know, you should be in a professional space and in this venue, but those are a little bit antiquated, to be honest. And so as,
especially
you know,
for children, right?
For children who literally live on their phone, and honestly, adults are starting to live on their phone, right? So we can't discount this technology and the amazing access it provides. But I do think, and I really also want to underscore Warren's point, when you think about the great digital divide, we have to make sure that we're actually reaching everyone. And that was something that came up a lot. And one of the questions that we added to looking at ACEs and other things that could be contributing to the environment is like, do you have access to internet, reliable internet? Because that's where we started to see patients actually start to fall apart when it came to schoolwork and to actual performance in schools, and just different access to there were so many things available, even access to vaccines, you know, early on that were all technology based. And if you didn't have that, that then created a greater disparity. So I think, you know, as we use these great techniques and we actually leverage them to the greater good, we have to make sure we're bringing everyone along.
Is reimbursement an issue for telehealth? Because it wasn't allowed before for certain things, and during the pandemic it was, and now there's talk about taking that back. Where are we with that? I've sort of lost track of that, is because I imagine that while it's very, very useful, if there's no reimbursement for it, it's going to be tough to keep doing that in a practice, no? I brought up a a nasty topic.
This is reimbursement for telehealth, telepsychiatry?
Yeah.
Oh yeah, so there's equity in terms of reimbursement for Medicaid as well as for commercial insurance for telehealth in terms of providing mental health services at this point. And I think one of the things that is continuing to sort of be advocated for, and I know that we've actually added telepsychiatry as a permanent part of our operating certificate with the Office of Mental Health, so that it becomes a standard of care, but it's a delivery option. So whatever is best for the kid or the family or the parent, so that we can provide those options. Audio only is the other thing that has also happened during the pandemic, is that some people don't have access to a smartphone. So being able to provide care through just audio only, telephone, and getting reimbursement for that is important. However, I think when we're talking about Article 28 primary care settings, getting reimbursement for the telehealth interventions, I think also is an issue that that is important to continue to advocate for. But as for mental health providers, there isn't an issue there.
So audio only is an option, and that's a little easier than the full-scale video telehealth. Is that what you're saying?
No, for some families, they just don't have access to a smartphone. So being able to have that access, like Sarah Ann had mentioned, is important, and making sure that there's sort of payment parity for those that are audio only, video on audio, and in person. So being able to have equity across that spectrum, but yeah. And some adolescents actually don't want the screen on. I mean, I've seen some adolescents, the last thing, they don't want to see their face, they're self-conscious, they want it turned down. So we try to broker with our young people, like what's comfortable for them, and also with our gender diverse youth and how they may experience their self-image. And so just wanting to be sensitive to every child's needs. And we know for our LGBTQ youth during the pandemic was particularly hard, with an increased rate of suicidal ideation, over half of those in one survey, but just understanding that the stressors sometimes of being yourself and sometimes not being able to leave your home and having to navigate that space is a challenge.
Interesting. Let's talk about two topics that have really sort of been taboo for a while, I think, when it comes to this: substance abuse and suicide or suicidal ideation. Talk to me about that. How do you identify the child that's really at risk or is, abusing substances? And then what do you do? I imagine that's a lot tougher than dealing with a child who's having anxiety.
I think when we're thinking about substance use disorders and adolescents particularly, it's just really important, again, to offer the opportunity to talk about it. So I think the first thing is to really set up a climate to say, this is confidential unless I'm concerned you're hurting yourself or someone is hurting you. Setting that confidential statement and actually adjusting it according to their developmental state. So what does the confidential mean? What does private mean? Using different words depending on their age, their maturity, and their developmental state is very important. Once you have set up this environment so that you can help engender a climate of trust, then the next step is really to discuss with them, tell me a little bit about things that bring you joy, bring you pleasure. Have you tried substances? Have you tried different types of things that make you get high, or asking them, why do you use it? We sometimes would ask them, do you do anything that helps you experience a high? But not always is that the case. So asking really just openly, have you tried any other drugs? Have you tried cannabis? Have you tried marijuana? And then one thing that I think is often overlooked is getting specific about what. If they say, yes, I do, we're not going to sit here and just try to attack the patient, but really it's about harm reduction strategies, understanding where they're at and how we can guide them to living a life that's healthy and full for them, right? And so the idea behind, grooming in adolescence is helping them become agents of their own advocacy. They should be able to advocate for themselves, but knowing is this harming you, and really doing motivational interviewing techniques to really understand where they're at. I think that's absolutely critical. I think one thing that's often overlooked, and I just wanted to bring up in this case, is that a lot of patients are using cannabis with tobacco, and they're often mixing it in. And so as we're thinking about strategies of how do we intervene? If a patient is really dependent on cannabis, are they also actually dependent on nicotine, and they may not disclose that to you? And so really asking questions and really providing a very open environment for that to happen. I think those are critical points to consider, but we do know from the data, there have been several studies from the National Institutes of Drug Abuse, as well as from other institutions that have shown that the use of marijuana has increased exponentially. Also, the use of illicit or inappropriate use of prescription drugs has also increased. So it's really important for us to know that we need to be really asking specific questions about what their uses are, why they're using it, and really identifying what stage of safety they're in. Are they at a point where they're truly using this as a method to consider suicidality? Is this a form of self-harm, or do they have really dangerous use that we're concerned about? So that's some of the elements that we want to elicit in our interview and our questions with our patients.
So Jonathan, how do you identify though the child that is at risk for self-harm, that they really are potentially considering or have, obviously if they've acted on it, suicide? How do you determine, who's going from depression to really getting acting on some of these thoughts?
Sure. Well, first of all, there are screening tools also, self-report screening tools. We use the one called the CSSRS, which was actually developed at Columbia, which is a self-report screening tool for suicidal ideation and behavior. And virtually every child or adolescent, well, I shouldn't say virtually, every child or adolescent that I see I have them fill out that tool before I see them. So, and a lot of times, believe it or not, children and adolescents will fill out some of these screening forms more honestly than they will necessarily talk about things in certainly with their parents and a lot of times with us. So I think the first thing is to screen for it. Second thing is to always ask about it. And it boils down again to what I guess Dr. Ng was saying about the rapport the pediatricians have with the child or adolescent to back into the conversation about suicidality from the conversation about everything else, you know, and there's a way to go about that so it doesn't come across as being out of context and make it seem like you're asking about, you know, screening. You're doing a screening questionnaire with the child or adolescent. So, you know, when you get into a discussion about depression, it's very kind of natural to say, hey, you know, sometimes when people are feeling down or sad or hopeless, like you say you've been feeling, they have thoughts about death or dying or harming themselves. And are you having those thoughts? And then obviously you have to get very specific about what types of thoughts those are. And particularly in terms of the screen, to what degree there's a method or intention or plan associated with suicidal thoughts and or behaviors. So we ask very specific questions that we've all been trained to ask about that. And when we get into the arena of children and adolescents who have the intention or certainly a plan to harm themselves, or what we call preparatory behavior, or what we call aborted or interrupted attempts to harm themselves, we start to get very, very concerned. But I think it's very important, not just with what Dr. Anderson was saying, specifics about substance use, but to really dig in to the specifics of suicidality and suicidal behavior, prior attempts or ideating about suicide, family history of suicide attempts or suicidal behavior, et cetera. And then major risk factors such as alcohol abuse. So there's a very significantly increased risk of suicide in association with patients that are abusing alcohol. So that's one very, very serious comorbidity that one wants to ask about when evaluating suicide. So.
And if you remember that the liquor stores were open throughout the pandemic, that was considered one of the essential services. So when you think about what young people have access to when they're not feeling their best or themselves, I think one of the concerns is that we're definitely seeing, on top of that, there's been a 31% increase in overdose deaths compared to the year before. And I know, Sarah, and you know these statistics really well, and you kind of see them every day. I think the comorbidity that Jonathan was talking about in terms of you're going to have often a combination of one thing and another. It could be alcohol, it could be marijuana use, as well as depression or anxiety. And suicide is definitely there. When you think before the pandemic, suicide is the second leading cause of death for kids 10 to 24. Just sit with that one. Second leading cause of death before the pandemic. So you can imagine, here we are talking about how much worse it's been. So I think if we need to feel comfortable to be able to ask those questions, but also get help and get support and get resources. Pediatricians can do a whole lot, and healthychildren.org, wonderful AAP website with a lot of mental health resources. Our AHCAP Academy website is also really resourceful, but there are also suicide hotlines as well as crisis text lines. There are so many different resources that you want to avail yourselves to, because kids are using technology in innovative ways. We want to make sure that they have the lifelines so that they can help themselves when they need it, or help their friend, because you know kids often tell kids before they tell someone else. Sure.
And I imagine that I think, as Jonathan mentioned, the technology and asking questions, the sort of not the person-to-person, face-to-face kind of thing that I think traditionally we thought was the more important way to interact with the patient. I suspect that they're much more comfortable with the anonymity of answering questionnaires and so forth. But Laura, then tell me, let's talk here before we run out of time a little bit about some strategies and coping skills for pediatricians to manage these patients. This is going to be time consuming. This is going to be not your typical patient. What can we offer pediatricians to help them with these not difficult patients, but more time consuming patients?
Well, just for another resource, I want to highlight the GLAD PC guidelines, are guidelines for pediatricians about how to treat depressed kids in their practice. It gives guidelines for when you might want to just be able to do support and monitoring if they are appearing to be mildly depressed, and then guidelines for using the PHQ-9 screening measure to help you figure out whether it's a more moderate and severe depression and when to refer, and also when to potentially start the medication yourself while you're referring for mental health psychotherapy services. But as I said earlier, you know, some of the strategies that pediatricians, I think, can start to work with are things like behavioral activation, mindfulness, recommending apps where kids can do some mindful meditation, problem solving. You know, it's pretty quick to teach somebody to problem solve, to just talk them through the few steps of how to generate multiple potential solutions to a problem. Think about the pros and cons and pick one that they think might have the greatest likelihood of success. We find that anxious kids and depressed kids tend to resort to suicidal ideation when they feel trapped, when they feel like they can't figure out a way out of whatever bad situation they're in. So if you can teach them the basic problem solving skills of learning how to, you know, generate multiple solutions to a problem, that most of the time they're not stuck, that there is something they can start to move the needle. They may not solve the whole problem immediately, but they may start to move the needle and solve smaller pieces of what's bothering them so that they begin to feel better. And then, you know, emphasizing the importance of social support and communicating with others who they feel safe, who they can identify as people who will be supportive of them, and strengthening those connections for them so that they don't feel like they're alone with their problems.
Interesting. As long as they're moving in some direction, there's some motion that's going to help. You know, as we're running out of time here, and what I like to do as at the end of our webinars here is to ask our panelists for a little pearl to take home, a nugget, a take-home lesson here that we want our audience to remember. If there's one thing that they'll take home and remember, this is it. And Evelyn, because you've been very quiet over there in the corner lately, you get to start out. Tell me what would you like our viewers to remember about what we've talked about tonight?
Thank you so much, Max. I would just like to say that pediatricians, as we've said, are on the front line and they're a trusted source, and that they should feel confident talking to their families and patients about how they're feeling. And they should do so the same way they do with physical health concerns, and they should use screens because they're, as we've said, going to help open up a conversation. They're not going to cause more concern. They're not going to cause, you know, children and families to do something that they weren't going to do anyway in terms of suicide and other things. And we can really help, and we're in a position to help. So we should feel confident in doing so. And there's help out there. So we put in a lot of links. Try not to be overwhelmed with all the links and the resources. Just pick one, use it, and we're here to help.
That's great. That's great. Well, I'm going to go across here because in the order of my screen, it may not be yours, but Jonathan, you're the next one up. What should we remember tonight?
Sure. I mean, I come from a narrative medicine background, and I'll put in a plug for Rita Sharon, who was one of my teachers from medical school. It's all about the story. And I think getting accurate information from children is not just about asking symptom-specific questions, but it's about forming a rapport and being able to get that history within the context of the narrative of an event and a child's life and a family's life. And I think you have to look at things and evaluate symptoms within that context and be able to elicit that story from the child or adolescent to get any meaningful information, and also to help establish the rapport with the child. So if I could say anything, it's always get the story. You know, we see children with symptoms all the time, and not any two of them are alike, obviously, and particularly at-risk children, just to reiterate a couple of things that Dr. Anderson, Dr. Ng have said. I think there's a generation now of children who were at risk beforehand, either because they had family problems, financial insecurity, challenges in their nuclear family, who now didn't go to school for a year and a half at formative times in their lives and didn't get help with learning and may have missed critical periods at the same time that the rest of their lives were in chaos. And now this, even after the pandemic, this population of children is going to grow up much more at risk. And I think being able to appreciate the web, and the tapestry of a child's life in terms of being able to understand them and to formulate interventions and to connect with children and adolescents is very, very important. So my take-home message is that.
Very good. Sarah, tell me something. Tell me something I want to remember.
I think it's important for us to know as pediatricians, as child and adolescent psychiatrists and psychologists, that we are actually at the forefront of really being able to create the next transformative leaders of our world. And if we're going to create a world that is equitable for all, we have to give our adolescents, our teens, the tools to succeed and the tools to live really rich, full lives. And so I think, at the forefront of their consciousness is this, as I mentioned before, syndemic of a pandemic that's really bringing out so much of the underlying structural inequities that people have experienced for a long time. So how do we help mitigate the effects of these longstanding structural inequities on top of the pandemic? And pediatricians, we have a key pivotal role in doing so. And so I do think for some pediatricians, it's a fear of not knowing. It's a fear of what if the suicide screen does turn out positive? What do I do next? But I think the greater thing to be concerned about is what if you miss it? And so I think it's so critical that as pediatricians that we stand in the balance and in the gap of creating these next leaders. And the only way we can do that is to ask and then be there and support.
Excellent, excellent. Laura, you are our, penultimate person here. Tell me something.
I just want to emphasize again the importance of the relationship with the pediatrician. Don't underestimate the power of your relationship to draw out these stories. As Dr. Slater was saying, is so important to get the stories of these kids, to use your relationship, to your role as a supportive person in the lives of these families, and to be able to instill hope by giving them some of these small tools to be able to see that they can make small changes on the way to bigger changes, and that those small changes can give them hope that things can change and that they can feel better. So I think those are things that pediatricians can do within their time-limited sessions, which they are so busy and overwhelmed by the need. But those are small, time-limited, brief things that I think can be extremely powerful. The importance of knowing that there's somebody there, there's somebody listening, there's somebody to support them, and then some of these small tools that they can take away. Great,
great. So Warren, as the chief, you get the last word, and somehow you managed to find a silver lining in the COVID pandemic a little while ago. What's your take-home message for us?
Well, thank you. I echo all of my incredible panelists, and thank you, Max. I think that there's so much wisdom and heart in this space for all of you, but I want to champion pediatrician and adolescent providers. You are the natural advocates. You actually champion kids in a way that I know inspires myself as a child and adolescent psychiatrist, but I would say use that advocacy arm because you have it and you speak on behalf of children. So within your communities, within your systems of care, advocate for the integrated care programs, for the school-based mental health, for suicide prevention, because if there's anyone who can get things done, it's a pediatrician and adolescent medicine specialist, because that's sort of who champions children's health issues. And also to appreciate that mental health conditions are neurobiological conditions that are treatable. So I think it's just really important for us to think that it's not just okay, but there is effective treatments based on the level of functional impairment for that child and suffering of that child. And when a kid's suffering, their family suffers. So it's really helping that whole family system. So thank you.
Yeah. Well, thank you. I want to thank all of our panelists. And what I am always amazed at when we do these webinars is how much help there is out there and how many resources are really out there to help with what seem to be difficult or even intractable problems. We're going to put that up for you. Also, the entire webinar will be up on the Columbia Children's Health YouTube channel by tomorrow. There's help. And there's a lot of positive things here that we can use to help our children. Just reach out, look for it, integrate it into your practice, and it'll help. Thank you all. Please help our kids. And oh, one more thing. Get a vaccine and mask up, please. We're not over this yet. Thank you, guys. Have a great night.